Introduce yourself, see.
I am Atulya, second year PG resident, BMH Calicut.
Sir, I am Ashna. I am second year DNB resident, Baby Memorial Hospital, Calicut.
Okay, you can present the case now.
Good afternoon, one and all present here. Today we are going to present the case of a 54-year-old male who is a tile factory worker presented with complaints of swelling and pain in the right groin region since 4 days, which was associated with multiple episodes of vomiting since 1 day. History of presenting illness. The patient started noticing a swelling in the right groin region in the past 7 months of about 3 into 3 centimeter in size, which was not associated with any pain, reducible and protruding with cough. Since 4 days, patient had developed pain in the groin, now irreducible, associated with 4 episodes of vomiting. The vomitus contains food particles and which is non-bilious. There is no history of fever. Past history. Patient is a non-case of type 2 diabetes on regular medications. He is a non-case of chronic liver disease diagnosed 2 years back on evaluation of abdominal distension and pedal edema. Since then, on regular gastromedicine follow-up. Patient had a history of hematomas 10 months back, for which endoscopic banding was done. There is no history of jaundice, viral hepatitis and TB. No history of hypertension, CAD, CVA, no history of COPD, bronchial asthma, no history of epilepsy, no history of any IV drug abuse, no history of any allergies in the past, no history of any surgeries in the past. Then treatment history. There is history of banding for esophageal varices 10 months back, no history of any other surgery in the past, and the regular medications are TAR propranolol 20 mg OD since 1 year, TAP glimepiride 1 mg OD since 7 years, TAP dapagliflozin 5 mg since 7 years. Personal history. He is living with family, reduced appetite, taking mixed diet, sleep, reduced normal bowel and bladder habits. History of melena 1 year back. He is an ex-smoker, was a non-smoker for the 10 years, stopped since 7 years, 1 packet per day, that is 10 pack years. History of chronic alcoholism for 20 years, stopped since 2 years, about 150 ml, twice or thrice weekly, and there is no history of allergies. Family histories within normal limits. Then general survey, patient is alert, conscious, cooperative, oriented to time, place and person, skin color is normal, face is normal, build average, nutrition average, decubitus, sitting comfortably on bed and gait normal. No pallor, icterus, cyanosis and clubbing. There is bilateral mild pitting pedal edema, hydration status normal, no gynecomastia, spider nevi, palmar erythema, neck veins not engorged, neck lymph nodes not palpable. Then skin scratch marks present, spine normal, no kyphoscoliosis, BP is 140/90 millimeters of mercury in the right upper arm in lying down position, pulse rate 70 per minute and it is regular, respiratory rate 14 per minute, SpO2 98% in room air. Airway examination, mouth opening 3 fingers, Malamati of grade 2, no loose missing tooth or buck teeth, neck movements adequate, thyromental distances 6.5 centimeters, sternomental distance of 13 centimeter and modified Lemon score 2/9. Systemic examination of the abdomen, local examination of right inguinal region showed a swelling of 3 into 3 centimeters noted in the right inguinal region, skin over the swelling looks normal, no visible pulsation, soft in consistency, no local rise of temperature or tenderness, cough impulse present and it is irreducible. Inspection, contour of the abdomen, it is mildly distended, umbilicus central and inverted. Skin over the abdomen, no scars, venous engorgement, moving normally with respiration, no pulsations or visible peristaltic waves visible, external genitalia is normal. Palpation, it feels soft, elastic, temperature is febrile, liver is palpable, 2 finger breadth below the right causal margin, soft, non-tender with smooth surface and sharp margin. Spleen is not palpable. Percussion, normal tympanic note all over the abdomen, no shifting dullness, upper border of the liver dullness at the 5th intercostal space in the right midclavicular line. Auscultation is normal. Other system examination, CVS, RS and CNS examination is within normal limits. Investigation showed HB 10.4, total count of 9,800, platelets 2.73 lakh, PT 13.5 seconds, INR of 1.4, BTCT with the normal limits, RBS 99, urea 30, creatine 1.1, sodium 135, potassium 3.9. And LFT is mildly deranged with total bilirubin of 2.1, direct bilirubin 1.7, albumin 2.8, globulin 3.2, AG ratio of 0.87, AST-LT with the normal limits, alkaline phosphatase of 210, HIV, HBs, AG and HCV are negative. ECG and chest X-ray are within normal limits. USG abdomen showed features of chronic hepatic parenchymal disease with portal hypertension. No ascites or portal vein thrombosis. So the summary is a 54-year-old male who is a non-case of CLD, child B, and type 2 diabetes mellitus on regular follow-up and medications has presented now with obstructed hernia and planning for a laparoscopy hernia mesh repair under general anesthesia.
Tired. No, we said you should present fast. Yeah. Oh, madam will allow another 2-3 minutes. Right?
We plan to finish it in 4 minutes.
Done.
That
Okay.
was the instruction given to them
Right.
by Bhaskar
So
sir.
in the flow you missed some important points also. When you say personal history and family history and all, no? Family history also becomes, you said nothing significant. It is important. So there are some diseases which have origin, familial origin, that's also there, contributing to a chronic liver disease. And I think history of blood transfusion, okay, some sexual abnormality, in the sense practices and all, we have risk of sexually transmitted diseases, hepatitis B and other things. So those must also be included, right? So you have mentioned it as a chronic liver disease. So what are the features based on your current presentation? Which are the factors favoring the diagnosis of chronic liver disease?
So the patient himself gives us a history that he is diagnosed with a chronic liver disease in 2 years, and also he is a chronic alcoholic. There is history of hematomesis in the past for which banding was done, and also in the examination, even though we could not find any stigmata of chronic liver disease, there is scratch marks in the skin, and also there is mild bilateral pitting pedal edema. When we look the investigation, we can see that the LFT is deranged with increased bilirubin and mild hypoalbuminemia. And the ultrasound finding is that there is chronic parenchymal liver disease with portal hypertension.
Yeah, so one thing everybody must remember is the investigations may not be always accessible. Okay, you are not expected to deliberately ask for investigation and try to come and discuss in the final examination. Majority of the times we say, are there some investigations done? You can have a look and come and discuss. Okay, that's first point. And secondly, when you say there is something like scratch marks, right? What does it indicate? Does it hepatic parenchymal disease or is it something else?
Sir, bile salt when increased can cause pruritus. And
Okay,
cause
so you said ultrasound has been done, there nothing has been found related to the gallbladder. It could be related to intrahepatic obstruction.
Yes, sir.
And because it's a chronic condition. Okay, and you have come to this diagnosis, but overall, what are the other causes for chronic liver disease?
Sir, there are many causes for chronic liver disease. In our country, the most common cause is alcoholic liver disease, but there are many other causes like non-alcoholic fatty liver disease, then chronic viral hepatitis is also a cause, then autoimmune hepatitis, other causes like drug-induced, then there may be hereditary causes like hemochromatosis, Wilson's disease, etc.
Yeah. So this patient, we had a clear history. You are lucky that you got such a patient. Some records are available. He had a history of esophageal varices being managed also, and some history of, there is a swelling of feet you have written? Swelling of feet?
Sir, mild pitting
pedal edema is there. So, and alcoholism definitely is there. So, what are the problems with alcoholic hepatitis, or long term it will become alcoholic cirrhosis also? Is it okay for us, and why you are bothered in this particular patient about alcoholic liver disease?
Basically, alcoholic cirrhosis is a end stage of alcoholic liver disease, and which is due to the intake of excess amount of alcohol for a longer duration. So it has 3 stages, that is steatosis, fibrosis, and cirrhosis. So liver is a major vital organ of our body, and it has many functions, like it is involved in metabolism of carbohydrates, proteins, lipids. It has role in coagulation and synthetic functions like synthesis of proteins like albumin and all. And it is involved in the metabolism of many drugs and detoxification and all. So since this is a vital organ, the derangement in liver function will affect the drugs that we are using during anesthesia. So what is our concern is during anesthesia, some drugs affects the That is, anesthesia affects the liver. That may, some drugs decreases the hepatic blood flow, some may increases the hepatic blood flow. The drugs affects the liver also. So we have to be very careful while dealing with the patient with CLD.
Yeah. So basically, liver, when we talk about liver, normally we always talk about jaundice. We are bypassing the topic related to jaundice. Of course, this patient didn't have jaundice. So de facto, de novo, whatever we say, jaundice is one hallmark of liver disease. So this patient has mildly raised bilirubin as per the shown investigations. And all of us should know, because discussion is very big for a liver condition, because we are using so many drugs. So the metabolism or pharmacokinetics of the drug could be disturbed, right? And the drugs we use can affect the liver function. And directly or indirectly, the drugs can precipitate some toxicity. And number 3, they can have effect upon the liver blood flow. So these are the things which are generally should come to our mind before we go forward. So questions will be too many. If you are lucky, if you are answering, you'll score a lot of marks. So that's more important here. And you have some examples of the otherwise hepatotoxic agents, drugs.
Sir, drugs can cause liver injury by different mechanism.
Yeah.
First is direct hepatic injury.
Yeah.
The drugs commonly used are like halothane and antitubercular drugs like isoniazid can rifampicin also can cause direct hepatic injury. Then other mechanism include cholestasis.
Yeah.
Chlorpromazine can cause cholestasis. Then other mechanism by steatosis.
Steatosis. So you have got 3 to different
Amiodarone.
ways they can affect the liver function per se. And we have to be very careful, including some antibiotics and all, with tetracyclines and chloramphenicol, they are all there. Okay? That's one important consideration. So now that you have seen the case and you have got some investigations done, can we have some mortality assessment in terms of some prediction scores? Are there? Do you know some?
Yes, sir. There is Child-Pugh scoring.
Yeah.
This is a classification system for assessing the severity of the liver disease. In this scoring system, there are 5 parameters are checked, 3 lab parameters and 2 clinical findings, which include total bilirubin, serum albumin, and prothrombin time. And the clinical parameters are ascites and presence of encephalopathy. And the score is given from 1 to 3, and 3 be the worst. And based on the score, if the score is 5 to 6, 5 is the minimum score, 5 to 6, it is classified as child A, and 7 to 9, it is child B, and more than that, it is child C. Based on that, the risk of
predict the
mortality.
Is it for incidental surgeries in CLD patients, or is it for transplant patients? Where is it applicable?
This is for incidental.
Incidental surgery. So we are not going to transplant aspects, but which scoring system? MELD score and MELD sodium are the other ones which are. So we will not go into the details. Now, this patient would be posted for, no, it's at practice nowadays, they are planning for laparoscopic hernia repair.
Yes.
Right? So is it okay? You will accept the case straight away, or you want to still do something?
Yes, sir, we can proceed with laparoscopic repair, since with some specific precautions and optimization of patient comorbidities. Since this patient is a non-case of CLD, but here he does not have any features of decompensation now, and he is active and alert, conscious, oriented. Investigations, only mild derangements are there in the investigations. So we can go for a laparoscopic surgery with some extra consultations and some extra investigations. We can obtain a medicine gastro consultation, or we can do electrolytes and magnesium levels in addition to the electrolytes. In such a manner, we can proceed with.
Yeah, so the consultation is very important. You again get in touch with the medical gastroenterologist, mainly because there is history of previous variceal bleeding.
Yes, sir.
So one of the dangerous consequences, patient is also on propranolol, beta blocker.
Yes, sir.
So I can get in touch with them, get the details, basically done. And chronic alcoholism, once damage is done, it's done.
Yes, sir.
Okay, I don't know how long he has not been taking. Any idea?
10 years.
Okay. So one thing we have to understand is magnesium levels could be possibly low in chronic alcoholics. So
Yes,
that's
sir.
one thing, apart from malnourishment and other things. So always have a thorough recheck of what is being done for the patient. And you had a list of all the investigations which you could access. But can you tell me, for example, 24 hours before you have a choice? So I will pick up one test which will be most reflective of any acute changes or immediate changes in the previous 24 hours. Like I will give you 3: albumin versus prothrombin time versus glutathione, yes, transferase. I am giving you a lot of clues, but you please answer it.
Sir, out of this, prothrombin time and GST will be a better indicator to check. Because in acute setting, that is, if there is acute hepatic injury, prothrombin time will be elevated because the procoagulants will have a very short half-life. Like factor 7 has a short life of 4 to 6 hours. So in acute period, it will be reflected. And in case of albumin, it is around 3 weeks, the half-life. And albumin can be decreased in other conditions also, sir. And about GST, that is glutathione as transferase, the short half-life is around 90 minutes. So it will be also increased in an acute hepatic injury.
So these are one of the stock questions. All of us should know albumin has got an half-life of around 28 days. Right. And of course, you know, there are many other reasons for hypoalbuminemia. Many simplest could be malnourishment or nephrotic syndrome and other things. It would not reflect directly what is happening in the liver, right? And when you say vitamin K dependent, we have the prothrombin time. Okay, factor 7 has got a half-life of around 12 to 16 hours. So it indicates it's not just a coagulation parameter. So PG should understand, yes, we are using it as a coagulation testing, but for short term, it could be a very good test of synthetic function. And GST, isoenzyme B, should be more specific. It could especially indicate that there is something in the centilobular area of the liver. Okay, so that's the most important thing. So finally, you said this patient had, history of varices. Okay, there was some edema, and they are all prone to complications. Chronic alcoholics. Portal means there is a history of portal hypertension. So there could be ascites. There could be, in fact, they can go to hepatic encephalopathy and all as the complications. If there is ascites in this patient, and what would be your management? Would you straight away again shift to OT, or you want to do something?
Sir, if ascites is present, first we have to look the patient clinically, whether the ascites is very tense or it is very minimal. And also we can do USG abdomen to assess the volume. And if it is very mild and not compromising the respiratory status of the patient, we can go ahead with the surgery. If there is a very tense ascites and it is compromising the respiratory function of the patient, we should do a paracentesis along with albumin, IV albumin, and it should be preferably 24 hours before the surgery, and after that we should repeat the lab investigation like serum albumin, then PTINR and sodium electrolytes.
Electrolytes follow-up must be done after paracentesis. Plus, you know, they have got hypoproteinemia. There is a tendency for fluid overload, and they could have used some diuretics, including potassium-sparing diuretics. So that's because we want to see that potassium is also not lost. So check for sodium, potassium, especially in the preoperative period. So that is the way you deal with ascites and prepare the patient. Okay. Now.
So now that you have taken a meticulous history, you have done all the investigations required for this patient, and you have optimized the liver function also. Diabetic status also you have optimized. So now the patient is posted for tomorrow's lap hernia repair, and you are going to see the patient today evening. So what all advice will you give to this patient?
So we are planning for a general anesthesia with endotracheal intubation and controlled ventilation. So on the previous day of surgery, first of all, I will speak with the patient and the bystanders, and I will counsel them about the complications, especially the bystanders, about the complications occurring during the surgery and also in the post-operative period. And I will get a informed consent from the patient and bystanders, and I will reassure the patient that we will take care of him without any issues, and then I will go through the pre-anesthetic checkup form, and I will cross-check the investigations. Then I will give carbo load can be given on this patient, but usually patients with CLD, there is a chance of gastroparesis, so carbo load should be given with caution. And I will add anti-emetics, H2 blockers to his drug chart. Then on the
we can follow the ERAS protocol also, no bowel preparation before, and we can give the NPO's guidelines for the patient. We can give incentive spirometry also.
Okay.
We will inform about the NPO status also, sir. 8 hours for the fatty meal and 6 hours for non-fatty meal and 2 hours for the clear fluids.
So when you are communicating with the patient, it's always reassuring. The patient knows that most of the educated patients know that he has got CLD or congenital heart, coronary heart disease, so I carry some certain risk. So it is your duty bound to reassure the patient, I will be with you, we will take care of the patient. And most of the time for any patient coming for the surgery, their biggest worry is that whether I will get pain during surgery or after the surgery. That also you can reassure the patient. And since the patient is on beta blockers, what's the protocol if any patient is on beta blockers?
Sir, I will tell them to continue the beta blocker on morning of surgery, and I will tell them to skip the OHO on morning of surgery, and I will check for fasting blood sugar and serum electrolytes on morning of surgery. Since the patient is diabetes and also he has a history of vomiting, so we have to check the electrolytes.
So you will check the FBS and serum electrolytes on the morning of the surgery, and you said you give antiemetics and H2 blockers on the morning of surgery. Will you give mechanical bowel preparations keeping in mind your ERAS protocol?
No, sir.
No, you won't give. To give ERAS protocol. And what about the antibiotic prophylaxis?
Antibiotic prophylaxis will give 30 minutes prior to surgery, sir.
So you have taken the consent, and now the patient is, imagine yourself, you are in the pre-medication room, patient has come for the surgery. So now tell me, what all things will you give?
I will repeat the dose of antiemetics and H2 blockers. And
on the morning of surgery?
Yes, sir. Then in the pre-medication room, I will give a titrated dose of short-acting benzodiazepines like midazolam under my supervision.
That so why do you want to give midazolam and titrated dose also?
So this patient is a case of CLD. So while sedating, sedation can prone to
and you counsel the patient so that his worry part is over. Anyway, you will give a small anti-anxiety dose, but you will give only titrated dose because what are you worried about?
Sedation can
precipitate hepatic encephalopathy, sir.
So you can go for decompensation. Yes, that's the worrying part. Now the patient is wheeled into the operation theatre. What is the next step?
First, whenever we have to attach the monitors.
Okay, you have read the WHO checklist and you are attached the monitors. Monitors, you can say that pre-induction monitors and post-induction
monitors.
Always keep in mind your patient only. This is the patient, 54-year-old child B. Okay, chronic liver. Now tell me, what are the pre-induction monitors and post-induction monitors?
Pre-induction monitors are pulse oximeter, then non-invasive blood pressure, ECG with lead 2 and lead 5, temperature monitoring. And
why lead 2 and why lead 5?
So lead 2 is the rhythm strips, sir. So we can assess whether the patient has any arrhythmias or anything during the peri-operative period, and also lead 5 for assessing the ischemia.
Okay, you will have the ST segment monitoring also.
Yes, sir.
Now?
Then additional gadgets like body warmers and calf pumpers I can keep, sir, because to prevent the thromboembolism, I will keep calf pump, and for to prevent hypothermia, we will keep body warmers.
Why are you worried about hypothermia in this patient?
CLD patients, there is a chance for delayed recovery, sir. In hypothermia, also worsen this delay.
Hypothermia is another cause for hepatic encephalopathy.
It can worsen if any
hepatic encephalopathy.
Yeah. Now, any importance of urine output? Usually, for bilateral hernia, they will put the catheters.
Yes, sir.
Yeah. Unilateral, they may not.
Yes,
so if they put the catheter, you can monitor the urine output also.
Yes, sir. Urine output monitoring is very important, sir. Since the CLD patients, there may be chance for high volume overload, sir. So we are giving a balanced salt solution in a goal-directed manner. That is, we are keeping the urine output in that is one
So that's also part of ERAS protocol.
15
So I will accept the your choice of anesthesia, let general anesthesia with the controlled ventilation and endotracheal tube. Is there any alternate way of doing it?
Sir?
Any alternate way of managing the airway? Supraglottic, you can do it.
Supraglottic airway devices we can keep, sir.
Yeah.
But CLD patients are more prone to get aspiration. So it's better to avoid supraglottic airway device.
So you
in
want a
case of
definitive airway?
Yes, it is
Okay.
not a definitive airway. In case of massive
Position
and
also
moderate.
maybe Trendelenburg or
Okay, yeah. So what are your choice of anesthesia? Anesthetic agents, I mean. And you have to justify your choices also. Why you want to use these agents?
So for
Induction agent.
I will prefer propofol, sir, in a graded dose. Propofol, because propofol has an extra hepatic metabolism also, so it can use in patients with CLD, and also it causes vasodilatation, so improves the hepatic blood flow. But we have to be very careful and should monitor hypotension and bradycardia, since CLD patients are more prone to get hypotension easily. Then for maintenance, inhalational anesthetic agents are preferred. All inhalational agents actually reduces mean arterial pressure and hepatic blood flow. The greatest with the halothane and least with the sevoflurane. In case of desflurane, least with isoflurane. But desflurane and isoflurane will produce some reactive metabolites, but sevoflurane does not. So we are preferring sevoflurane than other inhalational agents.
What about the muscle relaxants?
Muscle relaxants, I'll prefer atracurium or cisatracurium, sir, because atracurium undergoes degradation by Hoffman's elimination and ester hydrolysis.
Okay, so you have the choice of induction agent, inhalational agents, and muscle relaxants.
Muscle relaxants, sir.
What's your goals in the perioperative period for this patient?
The main goals are to maintain the hepatobiliary function and to preserve the blood flow. That is our ultimate goal. So for maintaining hepatobiliary, to preserve hepatic blood flow, we have to avoid sympathetic stimulation, avoid hypoxia, hypocapnia, hypothermia, hypoxia, then adequate analgesia, adequate depth of anesthesia, then judicious fluid management, avoid hepatic venous congestion, these are all.
Okay, any anesthesia plan which involves it's all multimodal plan, multimodal anesthesia. You have to plan the analgesia part also. That's important for this patient. What's your analgesia plans or options?
Sir, in this patient, we initially itself we are giving fentanyl for induction, and also we can give interfacial plain blocks like.
Which interfacial plain block for this patient?
Yes, depending upon the site of the port, where like if the umbilical port, we can give bilateral rectus sheath block, and for the lower abdominal ports, we can give lateral tap block.
Okay. If the surgeon is nice with you, he will say that I am planning to have the ports in the one in the umbilicus and one in the below umbilicus or above the umbilicus. So accordingly, you can plan the interfacial plain blocks. Which is the best time, before surgery or after surgery?
Ideally before surgery.
So why?
Preventing pain is better than treating pain, sir.
Okay. And also you can reduce the MAC requirement.
Yes, sir.
MAC requirement. So suppose the one umbilical port and the another ports are below umbilicus. What are your choices?
So for umbilical port, we are giving rectus sheath block.
So you're giving bilateral rectus sheath block.
Yes, sir. Under USG guidance.
Yeah.
For other ports and for the surgical site, we are giving lateral tap block. Ilioinguinal iliohypogastric block can also be given if it does not interrupt the surgeon's mesh.
Okay. Any other block?
Quadratus lumborum
QL
block can
QL block
also
also.
be
It's a
given.
unilateral block. You have to give on only one side also. Okay. Now you have shifted the patient in the postoperative area. And after 30 minutes, after around 3 hours, you get a panic call from the sister. That's now the patient's blood pressure is dropping. It was 110/70 when you shifted. Now it has come to 90/60, and the patient is tachypnic, respiratory rate is around 28 per minute, and tachycardia, pulse rate is around 124, 130 per minute. And so what are your differential diagnosis? What all things will you keep in mind?
Sir, a postoperative patient developing tachycardia, tachypnea will be...
in this contest also.
Okay, sir.
You have to keep in mind of this patient. You are just shifted the patient, you know about the patient, and you are planning to, you are doing the other case. In between you got a call.
Sir, I will be rushing to the postoperative ICU
Definitely.
and looking the patient, and definitely I will go in the ABCD guidelines. I will follow that.
Now, what are the possible causes? In between when you walk, you think about the possible causes also.
Sir, this patient is a postoperative patient, so tachycardia, tachypnea can be due to a cardiac event like pulmonary embolism, or there may be...
Tell me more always. See, that's a mistake everybody does. For example, Gurudhar sir gave a simple hint also. For one of these, we keep on discussing about lighter places of anesthesia in a different context. There are some contexts, not here. So as anesthesiologists, our primary concern is, for example, pain.
Pain.
Understand? Again, all of the tendency for postgraduates to go to exotic reasons and diagnosis as the first point. So that, you have seen pulmonary embolism, how many you have seen in any case? Right? You have seen pulmonary embolism cases?
Yes.
How many?
2.
Huh?
2.
No, good.
Lucky.
Okay. So don't tell unusual things. So what happens? You have this patient. He is diabetic also. He is given general anesthesia, the usual conservative one. Everything is done. What Dr. Rajesh is telling is patient is shifted to the post-operative ward. Suddenly there is like tachycardia, tachypnea, desaturation, and you are sent for a call. Yeah.
Sir, this is a laparoscopic procedure, so
Very good. Yeah.
pneumoperitoneum created. So
That's also a
That's why
factor.
you have to think about the context.
What is the
so
context here?
pneumothorax or subcutaneous emphysema can happen. Post-op atelectasis can happen. That all can cause tachypnea and saturation fall.
Pulmonary edema also.
What will be the commonest cause? Again, pneumothorax or pulmonary edema?
So pain.
Pain, first of all. We know this is a laparoscopy and pain will be less. But still, no, the pain sensitization, no, the threshold will be different for different patients. An anxious patient.
And he is diabetic also.
He's diabetic. Why it should not be hypoglycemia, for example, right?
Yes, sir. Hypoglycemia.
Understand? So think of all the normal, simple possibilities. Okay. So when the patient is shifted outside, rule out other things. You get a ECG done for the patient.
I'll check the
So
vitals.
you have a few
Check the vitals.
certain DDs in your mind, possible causes. So how will you exclude all these causes? What are the investigations you want to do? I mean, all lab investigations or any non-invasive investigations?
Sir, I will order for an ABG, ECG,
Yeah.
then other electrolytes, and also we can do
So you can do
focus,
blood sugar also.
Yeah, blood sugar.
Of course, it
Blood
will come
sugar.
in the ABG, but still you can, it's a diabetic patient, and you can always go for the
So that's
blood
also
sugar.
again, I again recommend now.
Yeah.
You said what? ABG, ECG, electrolytes, sugar. You came in the reverse direction.
First thing is blood
It
sugar.
should be blood sugar first, right? ECG, right? Electrolytes, then ABG. Okay, don't go to the ultimate investigations. Yes, they could be indicated. Go from the simplest, most plausible things. Okay, then go to the next level. Yeah.
So that you have done the lab values, everything is okay. Then
Sir, we
you
can
are,
also do a POCUS.
yeah, very good. You can do a POCUS also.
Yeah.
You can assess the volume stresses. You can do a TE also, TTE, transthoracic echo, and see the LV also. Okay, all these things you have to keep in mind.
I think PGs can understand. Point of care ultrasound, we had a workshop also yesterday. This is one situation where we can still use it beneficially. Okay, this is not a full-blown chronic liver disease, but whenever there is a discussion, we have suspicion. For example, you said, now you go to the other extremes. We go along your pathway. If there is something related to the fluid overload, okay, we can just check the lungs, then you can check the inferior vena cava of the patient. Okay, then the collapsibility index, right? Then if it is a pneumothorax or subcutaneous emphysema is one of the problems in laparoscopic procedures, that could be precipitating the problems. Understand? And of course, the echo, if you have got doubts related to the heart. So, a point of care ultrasound involving the echo in the lungs and of course, the IVC collapsibility index, they are all very much in place for this patient. Okay.
So,
then I think I just want to convey, because liver is one of the biggest things in terms of discussion. It's an organ of metabolism. So you will be asked questions about jaundice per se. What is jaundice? What is the metabolism, metabolic things related to jaundice, types of jaundice, right? Then the metabolic pathways, type 1 reactions, type 2 reactions, okay, what is oxidation, what is oxidation, reduction, okay, hydrolysis, all these steps will be asked one by one, okay. And in fact, with respect to the metabolism of inhalational agents, so we should be trying to use, with respect to the inhalational agents, the agents which are least dependent upon the liver. So can you give me how much of halothane is metabolized in the liver?
20%.
ISO, CO, desflurane and all, how much, to what extent they are metabolized in the liver?
Halothane 20%.
Yeah.
Sevoflurane 2%.
Yeah.
Isoflurane 0.2%.
Yeah.
Desflurane 0.02%.
0.02%. So it's like a rule of 2. It's easy to remember. Halothane would be around 20. CO will be around 2 to 6. Then ISO will be 0.2. Desflurane will be 0.02. So logically speaking, we can pick up the agent which depends most minimally on the liver, and only that much is a metabolism. The rest of it is gone through the expired air. Okay, that's the most important thing. Okay, and when you even spoke about the induction agents, so we can always have a combination of drugs. Okay, because when I say propofol, okay, especially we had senior examiners, everybody will ask how propofol undergoes metabolism in the liver. Okay, stock questions for us was thiopentone. Madam would know how thiopentone undergoes metabolism, various steps. You must be knowing how, for example, vecuronium is broken down, rocuronium is broken down, how propofol is broken down, right? How succinylcholine is broken down?
Butyryl is
How? How many steps? See, these are, you heard Dr. Venkatesh sir, Ramkumar Venkatesh sir speaking about succinylcholine. It's like the bread and butter for airway management even now. Okay, we are not, no, it is addressed to everybody, all the PGs. We are not able to answer the succinylcholine. Okay, it undergoes two-step metabolism. Succinyl dicholine gets metabolized to monocholine and choline, and again monocholine to two molecules of succinylcholine, succinic acid and succinyl. So this is very important because they have got hypoproteinemia, CLD patients. Okay, so that's the thing we have to remember with relation to the liver overall. Okay, which could be the best opioid?
Remifentanil.
given the choice.
Remifentanil. Why?
Because it is rapidly metabolized.
Yes, by ester hydrolysis.
Which could be the best benzodiazepine, provided it's available to you.
It's now not available.
Huh? So you should hear the clues from the examiners also. He says, internal says, it's not available. So that's a clue for you. So Remimazolam would be, if available, the best benzodiazepine. Remifentanil would be the best opioid, right? Inhalation agents, you said, for example, in terms of liver blood flow, best one would be isoflurane. Because in fact, it even produces some sort of improvement and vasodilatation as compared to other two agents. And just to remind, halothane hepatitis, people are fond of asking. I don't expect that questions will not come also in theory. Suddenly you may get a question on halothane hepatitis. You please go read through it, because still we learn from history. Okay, so those things are very important, and of course we have problem related to MH and other things. Okay, So this is the thing which you have to remember overall. Okay. So thank you very much. What will be the assessment of NMC inspectors here?
Externally.
Huh?
Can we pass them, sir? Yeah.
So these are NMC inspectors. Distinction for them. Okay, thanks a lot, madam. Thank you.
Thank you, madam. And the entire organizing team.
So well done. And because I heard from Rajesh, they have just completed 1 year. So that way also, it's a good performance. Okay.
Because
So thank you
our
very much.
finalists has got
Yeah.
exam on June. So DNB exam.
So reflects on the teacher also.
But they have done a good job, great job. So it's a learning opportunity for them also. Thank you once again, the entire organizing team of the WIMS. Some of the questions are out of syllabus. Spontaneously.
Thank you, doctors. Now, I request Dr. Bala Bhaskar to kindly distribute the participating certificates to Dr. Atulya and Dr. Asna. Now, I request Dr. Venugopal sir to kindly come to the stage to felicitate Dr. Bala Bhaskar. I also request Dr. Manjit sir to please come to the stage to felicitate Dr. Rajesh.